Good morning or afternoon. My name is Tracy Cook, and I'm with Sachs Healthcare Communications. Before I introduce our moderator and speaker, on behalf of Medtronic and Sachs Communications, we would like to thank all frontline workers in our audience for your commitment and passion in helping all of us through this very difficult time. We are truly indebted to you all. I would like to show our audience today how to send in your questions, when we will answer as many as possible at the end of the session. Our moderator is Angela Craig. Ms. Craig is a clinical nurse specialist for ICU at Cookeville Regional Medical Center in Cookeville, Tennessee. She is also the sepsis coordinator for her hospital and is on the Sepsis Network Advisory Committee for Sepsis Alliance. She is an expert in the field of sepsis awareness and management. Ms. Craig has published and lectured extensively at numerous nursing conferences and webinars on the topics of sepsis and hemodynamics. Angela, welcome.
Good morning, good afternoon, depending on where you're at in the country. Thank you, Tracy, for that very kind introduction. The title of today's webinar is A Long Day's Journey into Life, Using Prediction Methodologies to Prevent Decompensation and Death. And speaking today on this very timely topic is a colleague and friend of mine, Barbara McLean. Now, Barbara McLean has worked in critical care practice for 40 years. She guides the rapid response team on modified early warning systems. She works every day to improve outcomes for patients and their families and safety for staff. She remains clinical. She is a sepsis hero. She's actually my hero. And she stays in clinical practice and speaks around the world. So we're really excited about what she's going to share with us today. The speaker has disclosed that there are no relevant financial relationships in reference to this presentation. And continuing education for physicians is available, and you can see the accreditation statement below. Continuing education for nurses, respiratory therapists, and EMS professionals has been approved for 1 contact hour, and a link to obtain the CE credits will be available at the conclusion of this webinar. Support for this educational webinar has been provided by Medtronic. So now I'm going to hand it over to Barbara for this awesome presentation.
Thank you, Angela. I so appreciate it. Welcome to everyone from around the country and I hope around the world. Good day to all of you. And I add my thank you to all of you for what you do every day in taking care of patients and keeping patients, families, and staff safe. I'm very grateful to Medtronic for the opportunity to speak today about utilizing prediction methodologies and evaluation methodologies and just remote monitoring to allow us the capability to do a better job of predicting our patients' decline and understanding decompensation before patients enter into the vicious spiral towards death. Today, we will actually identify some of the strategies that are necessary for effective clinical monitoring, discuss machine learning and predictive methodologies, and relate that to the human factors and our basic limitations, no matter how much we wish to do the right job, no matter how smart we are, that we are human, and to relate those factors to the issues at hand with patients at the bedside. And then to discuss that application, early warning, rapid response, and improving patient outcomes. And so, to begin, we think about our daily bread. We're always at the bedside, and most of us work 12 hours. Sometimes we work 14 or 16, especially during our current pandemic crisis. And in our 12-plus hour day, we frequently deal with alarms, false alarms, real alarms, specific alarms, sensitive alarms, so much so that perhaps we ignore some of our alarms. Those alarms, in some perspective, will actually lead us to a code situation, either respiratory or cardiac arrest, typically, patients stopping breathing, having an opioid overdose, or just plain decompensation. How often does that require a rapid response call? How often are we calling a code sepsis? And how frequently are our patients presenting in decompensated state? And in particular, as it relates to today's environment, where we may be donning and doffing PPE, going in multiple rooms if we're on COVID areas, COVID floors, COVID ICUs, and how much that's limiting our ability to actually fully evaluate the decompensating patient. So we certainly know, and we've known this for quite some time, and there are so many clinicians that have gathered the evidence and looking at the information that up to 66% of in-hospital cardiac arrests are preventable. That is a stunning number. That number actually indicates to us that we may have had 1 to 4 hours of prediction with abnormality of vital signs prior to that cardiac arrest. And we all appreciate that you can survive an out of hospital arrest with a provider at the arrest who was providing CPR almost significantly more than you can survive an in-hospital cardiac arrest because of the comorbidities and the deterioration of the patient that's occurred prior to their actual arrest scenario. So we really do appreciate, that oftentimes deterioration can go unrecognized. Now, one of the reasons that deterioration goes unrecognized is not that nurses and physicians and therapists are not acting on those vital sign changes or the deterioration of the vital signs, but because they might not see that deterioration, and also because of the specificity of the vital sign prediction in isolation is not as meaningful as it is in aggregate. And even in an aggregation of things like heart rate, respiratory rate, blood pressure, and pulse ox, we still may not be capturing deterioration until it's almost too late. So I want to just correlate that to what I might say about pediatrics. By the way, not knowing much about pediatrics, but really appreciating that hypotension is the very latest sign in a pediatric deterioration. So now I want to correlate that back to adults and say most of us are focused on the heart rate or the respiratory rate or the blood pressure and the pulse ox. But that may not be the best aggregated information to predict patients who are actually decompensating. So we certainly know that after evaluating patients and looking at adverse events in hospital, in patients, the very most particular information was that frequency was not enough. So in my hospital, if you're on a medical surgical area, your vital signs are every 4 or maybe every 8 hours, depending on your acuity. And of course, the issue is that a patient is not acute until he becomes acute. And so the observation frequency may not be adequate to evaluate those patients who are deteriorating. Now, asking bedside nurses on top of their very high level intensivity, and again, particularly in this time period with the pandemic crisis and the PPE, we may not be able to put an additional burden on them, even though they're willing to accept it in order to do the right thing for patients. So we have to think about that the absence of that observation and absence in recognition of minor or major changes in vital signs may not be detected appropriately, and that there may not have been any action taken. And again, I want to say that nowhere in the literature does it say people didn't want to take action. It's that based on the acuity of their day, their patient acuity, and their bundle of patients that they're caring for, that some of that may be missed because of a reduced frequency of evaluation. And that's why our focus is really most particularly outside of the ICU, because outside of the ICU, we have a reduced observation period. Now, when deterioration is recognized and help is requested by the bedside staff, sometimes there's a delay in the response of the provider, in the appropriate medical attention that's given to the patients. And of course, anyone who knows me is also aware that I talk a lot about failure of our communication skills to actually communicate urgency in a scientific manner. So we look at all of those issues: the frequency of observation, the awareness of changes, the communication with our providers, and the immediate action. Those big four issues that have been discussed time and time and time again. So we really appreciate that when we're talking about our patients, that we have to think about the journey that we are on with them, that the proper management of these patients within the context of our system, our staffing ratio, our capability, is to make a commitment to identify patients at risk as early as possible. And most particularly, to focus on the immediate problem that might actually terminate the patient's life, and taking and performing and intervening quickly. All three of those: taking the measures, performing the actions, and communicating the issue, and being able to do that quickly. Now, the best way, of course, is if we're all electronically connected to each other so that we can actually see what's occurring at the bedside. And when we've been notified, or even if we're just monitoring, we're seeing these changes and we see them quickly. It's important to remember that any patient in the hospital is vulnerable. And as they become unstable and the complexity of their illness unfolds, that makes them more likely for the development of deteriorating conditions. Now, historically, we would say most patients on a medical, surgical, or step-down area, that those patients are at high risk, primarily related to the possibility of sepsis. But today, I would say sepsis, COVID-19, and the two together, that those patients might be breathing well when we look at them, and they have nice compliant lungs and are responding to high flow oxygen, and then they lose their lung compliance and they have microthrombi, and now we see ventilatory changes, oxygenation changes, but ventilatory changes first, oxygenation changes, and vital sign changes, and that happens so rapidly. So what is it that we can try to do to actually perform better methodologies for evaluating our patients? So we always want to think about being part of that journey, to remind ourselves that not only is it about the bedside nurse who is evaluating that patient, and not just about their fund of knowledge, but that the host response, the process, and appreciating that no two patients will present exactly the same way. Now, we know that our systems are based on a theoretical structure of complexity. We have monitoring, we have alerts, we have physical restrictions in our units and in our methodologies. We may have communication to a central station, but what nurse is actually ever at the central station? None that I know. They're out looking at patients, doing patient work. So we think about all of those relationships and bring that to the integral triumvirate, which is the bedside provider. That would include respiratory therapists and techs and nurses, our physicians, and our specialists, and how we have that triumvirate communicate together, and how we assure that we all have singular goals of therapy, and that we're also aware that those goals are always changing and our interventions are always changing. So in order to make that applicable, we must be able to say, we will detect early on, as best as possible, as best as humanly possible, as best as systemically possible. We must actually evaluate early patient deterioration and failure. So the goal, of course, of early detection is to reduce that patient's journey into the end of life and progress that journey towards survival. Now, we know that there are many causative factors in deterioration of patients. They can be neurologic, they can be cardiac, they can be ventilatory, they can be oxygenation. And so it's very difficult to say there's one measure or two measures or even three measures that give us this information. Now, that's really what drove the desire to bring the basic vital signs and other parameters, and now integrating laboratory evaluation as well, into a predictive methodology, predictive software, or early detection methodology that tells us about patients who are actually at risk for rapid and profound deterioration. So we just think about that relationship and we remind ourselves that 60% of patients had at least one abnormal vital sign 1 to 4 hours before cardiorespiratory arrest. And actually, the more vital signs that were abnormal, the higher the prediction for mortality. So we look at our abnormals and our severe abnormals, and we look at that percent of mortality, and we look at the aggregation here where we talk about 3 abnormal vital signs, particularly if they're severely abnormal, that is 100% predictable. But most of us are focused really on what the heart rate is, what the mean arterial pressure is. In general, if we're monitoring respirations and we're monitoring that continuously with electrodes and electrode pads, having the pads in the right place, really looking at intrathoracic diameter change to tell us about the respiratory rate, that oftentimes is inadequate. It might not have been applied properly. The patient maybe took his leads off. The leads are old. They've been on for greater than 24 hours and they're in the incorrect spot. So we have to think about, first and foremost, most importantly, is at the bedside, we need to assure the best possible signals in order to give us a good prediction of abnormal vital signs. And the best signals that we can create are, first of all, if we're monitoring continuously with changing our electrodes and our electrode pads and making sure that the signals are vibrant and robust. And if we're not actually monitoring that, actually putting our stethoscope on our patients and listening to breath sounds for 30 seconds in order to predict the respiratory rate, which is going to be one of the best indicators of deterioration. So now I'm just going to take a quick look at Mr. Sick, who comes into the emergency department. He's a previously healthy 32-year-old African-American male who presents with a little alteration mental status. He has no focal deficits. The belief is that he has a drug history. That's how we evaluate him. That's what the family reports. And he's had some upper respiratory symptoms for the last 4 to 5 days with a little bit of shortness of breath and just some itching, really feeling like his lungs are itchy on taking deep breaths. Now today, he's a little weak and sleepy and lethargic, but look at his vital signs. His heart rate, of course, is something we're going to be quite concerned about because he's quite tachycardic, but because his pulse ox is 100%, he has a good looking pulsatile flow, and his respiratory rate is 20, we say, okay, I'm a little bit worried about this guy, but not that much, and his saturation looks great. So I've got 4 or 5 other patients that I have to look at. I think he's going to be okay. He's kind of flying through this. I'll be back to his room in about 3 hours. Well, that would be reasonable, except of course that we're looking at a patient who actually is projecting some deterioration in this scenario. So the first and most important thing is when we think about our traditional methodology of monitoring, particularly outside of the intensive care, when we think about how we monitor, we remind ourselves that frequently, if a patient looks okay, they smell okay, we think they're okay, we might be taking their vital signs once in 6 hours, once in 8 hours, or perhaps once every 4 hours, which gives a huge window of opportunity for deterioration. So in 2008, looking at ward nurses who were working 10-hour shifts, 35% of their time, I think that's a profound underestimate, is spent on documentation. I would tell you in my practice, I think about 45% of our time is spent on documentation. And by the way, just as an aside, I think that information technology is a fabulous method to help us and assist us in doing the right thing for patients and assuring we've done the right thing. But I want that to reduce the amount of time that I'm documenting so that I can increase my time spent on patient assessments, spent on time with my patients, spent on time with my patients and my families. So we have to consider that in this study in 2008, which I think underestimates where we are today, 35% of time was spent on documentation and only 7.2% of time, 31 minutes in a 10-hour shift, spent on patient assessment. No wonder patients get past our evaluation. We don't have time. We're not able to do what we need to do at the bedside. So we really do want to use technology. So this isn't necessarily your EMR per se, but the utilization of technology in continuous monitoring of heart rate and respiratory rate, which can significantly reduce length of stay. It can profoundly reduce ICU stay days and significantly impact cardiac arrest outside of the ICU. Wow. That's so amazing. And then if we look at even a bigger integration of continuous monitoring, of continuous blood pressure monitoring, continuous pulse oximetry monitoring, continuous end-tidal CO2 monitoring, how will that bring us to a better safety net for our critical patients? How will that allow us to do a better job? And how do we make that happen within our own institutions? So very important to remind ourselves that we have our EMR, which is taking a lot of our time, but we also have the capability to utilize artificial intelligence, predictive software combined with provider intelligence. So AI and PI, provider intelligence, married together to give us methodologies to effectively monitor our patients. What that does is say, for all of us, we know that spot checks have not actually benefited our patient. That doing intermittent visual monitoring of breathing, oh, he looks pretty good. It looks like it's normal. It's around 16 times a minute. What he looks like, what muscles he's using, what the color is, what the color of his skin, what the temperature is. These are good spot checks, but they are just spot checks. Fingers on the pulse, a good spot check, but it's just a spot check. And blood pressure evaluation. We know that blood pressure evaluation, particularly with oscillation methodology, which is your Dynamap, your automatic blood pressure cuff, is fraught with errors and may not give us a good evaluation of our patient's correlation of heart rate to blood vessel tone, vascular tone, that we really aren't able to truly monitor our patient effectively. And in today's world, we want to look at the ability to provide monitoring that integrates all our data together, special purpose monitoring that we can apply to patients who appear to have a more significant illness or more probability of deterioration, and then looking at that relationship, integrating that together. So looking at pulse ox, looking at end-tidal CO2, looking at a continuous blood pressure, a continuous respiratory rate, a continuous heart rate, and how we integrate that together with all of our special purpose monitors and our existing monitors. And it's very, very, very important for us to remember that many of the problems that we have today is about cost control, reliability, and artifact. So again, I want to reiterate here, one of the most important points no matter where you are, no matter what country, no matter what shift, no matter what. If you are monitoring patients continuously, we must have a commitment to assuring that the signals are appropriate, and we do that best by just changing our monitoring pads every 24 hours, making sure that they are in the right space, making sure that we don't have artifact in our monitoring. That's something we can all do right now today without any extra cost, significant extra cost. But in general, we have so much data. We're so busy. We're so short-staffed that we've forgotten the urgency and the immediacy of assuring that whatever we're monitoring is valid. And then, of course, the question is if what we're monitoring is actually doing what we want it to do. Well, we know that spot check monitoring may be profoundly and severely inaccurate. That intermittent pulse ox spot checks miss 90% of prediction of hypoxemic episodes. That's a really important perspective. And I want to remind you that your pulse ox may stay constant and look adequate 2 to 5 minutes before you actually start to see a deterioration. And that's one of the reasons that we talk about other methodologies to do spot check monitoring, and in particular, looking at something similar to end-tidal CO2. Now, we also know that opioid-induced respiratory depression is a very significant problem, and 97% of post-op respiratory depression related to opioids are preventable if we have a better monitor, we have a better response, and if we actually apply that continuously. So continuously monitoring actually helps us to increase the chances of early recognition and profoundly reduces the deficit that we see. So in 2017, beautiful study that looked at improvement early detection of oxygen desaturation was actually applied with continuous monitoring. And that continuous monitoring actually applies to not just the pulse ox, but the end-tidal CO2 as a primary indicator of ventilatory failure or hypercapnic disorder before hypoxic dysfunction occurs. So really important for us to think about how we're going to use that continuous monitoring. So one of the most important aspects of this is how is it that we actually know that a patient is deterioration, and what happens when we believe that we see deterioration. So in my institution, we have a very aggressive methodology for actually communicating to rapid response. And for us, we use a modified early warning score tool that actually uses our EMR, predicts patients at risk, and communicates directly to rapid response. So reducing some of that human factor methodology, but certainly increasing the work burden of the rapid response team. So oftentimes prior to the integration of modified early warning system scoring tools, we actually saw that isolated criteria that were extremely abnormal were what drove a rapid response call. But by that time, that patient was nearly in a cardiac or cardiopulmonary arrest situation. Because the more subtle signs that actually can occur, that actually will indicate deterioration, were not being communicated because they weren't necessarily being observed or documented. So we looked at all of the data that was available at the time that we built our early warning score tool, scoring that multiple indicator criteria to predict patients who are deteriorating. Now, because so many of our patients enter our hospital already quite acutely, we had to actually change some of the scoring mechanisms and what we thought was the most important to try to reduce the amount of false positives that were relaying a rapid response call. But it is really important to remember that modified early warning score systems examine multiple criteria. They aggregate multiple criteria, and everywhere in the world today, we're all trying to actually make this more specific, more particular, less sensitive when there's not really an issue, but more importantly, more specific. So early warning scoring systems have been around for a long time. They were introduced in the 1990s. The Joint Commission, the IHI have all taken on uh, the advocacy for the utilization of early warning systems at the bedside in all of our hospitals in order to assist us in the prediction of patients who are at risk. So I'd like to show you the basic early warning score and then do some comparative analysis between this is the English National Early Warning Score, the modified early warning score, which is what most of us use, the Scottish early warning score, and the Wellington early warning score. So the primary areas that actually brought early warning score forward were really the UK. So England, Wales, Scotland. And the Wales scoring tool is the one that's really driving our movement forward. But we're all trying to do appropriate evaluation. So you can see that in MEWS, urine output is not part of that evaluation. In MEWS, SpO2 and supplemental oxygen historically has not been part of that evaluation, but urine output is. In SOS really, you can see that supplemental oxygen is not considered and urine output's not considered. And in the Wellington score, you can see SpO2, supplemental oxygen, temperature is not considered. So all early warning score tools are not the same. And actually, most of us build our own scoring tool based on our patient population using some or all of these correlates with look-back methodology for level of consciousness, look-back methodology for urine output. But in addition to that, what I would venture to say to you is that we have some other vital sign capabilities that are present and future that will actually assist us in doing the real interventions in real time and right now. So we just remind ourselves that aggregating our vital signs together gives us a scoring tool that allows improvement in quality and safety of management of our patients. Our primary purpose is to prevent delay in intervention, to prevent deterioration of patients to the point where they require an ICU stay, or to the point that we actually have a code blue. So the idea is to aggregate our data to predict patients at risk. This is a beautiful idea, and it's been around a long time. This is not new. But methodologies of applying this are still a struggle for all of us, and making these methodologies, again, more specific. The methodologies right now are really, really sensitive. That means they fire a lot, but they're not specific enough, meaning they fire a lot without a reality base. And that's what we're working on in today's process. So for us, this is how we've been using it with systolic pressure, pulse, respirations, temperature, and level of consciousness. And that's what we've been using. And what that does is it aggregates your vital signs. And when your vital signs are abnormal, you have a score. And that score extends out to number 5. So when I have a patient who has an aggregate score of 1, that means really the likelihood is they have a little bit of abnormality, but it's not profound. And when they get to 2, this is a profound abnormality. And so the prediction of deterioration is based on the scoring of these aggregate vital signs. And that gives us such great information because it brings that all of that data together in a predictable score. In my institution, we use MEWS as an early warning system to gather together basic neurologic assessment using GCS and changes in vital signs, and they all have their own scoring capability. For us, we typically see patients admitted with a score of 4 to 5. So you must be greater than 5 or you must have had a change of at least 2 points in the prior evaluation to help focus on who's at risk. And for an EPIC BPA, EPIC being our EMR system, and BPA is a best practice alert. EPIC sends a BPA, a best practice alert, to the rapid response team if the score is greater than 5 or if there's been a change of 2 points in the prior evaluation. Now that has helped us to actually bring our patients into a much more profound safety net. And we also know that if we can do this in a way that bypasses the requirement to go to the central station, to go to the bedside, but to actually have this information transferred in a surveillance methodology that's electronic, a pager, a phone, an iPad, whatever it is that your bedside personnel can carry and keep with them at all times, that surveillance methodology can significantly and profoundly improve outcomes for patients. So for us, our EMR, we've developed a methodology that the EMR sends a best practice alert with the patient's current vital signs, their score, and their prior score, so that we actually can see, did this patient get significantly worse, and in what time did they do it? Now that's made it more specific for us, but it's not specific enough. Now, since the introduction of modified early warning score in my institution, what you can see is inpatient code blue, non-ICU has gone down, down, down. So this is all code blues, that includes the ICU, and this is the code blue outside of the ICU. So singularly, just the basic methodology that we used, which is looking at heart rate, respiratory rate, blood pressure, pulse ox, temperature, and change in level of consciousness, we have significantly reduced code blues at my institution. And that is not my work, that's the work of the rapid response team, their leader Rashanba Rogers, their prior leader, Andrew Mady, and the EPIC ClinDoc team that helped build these strategies. I'm just a guider. I'm not the worker. Other people did that work, and this is so incredibly significant. I think that it's hard to avoid the importance of this information. And of course, it could be better, because if we look at the calls in 2018 and 2019, alerts, 11,709 alerts. So we continue to massage the meaning of the MEWS. And you can see that over time, we've reduced the majority of MEWS alerts, or alerts that patients are deteriorating, making them more specific, not wanting to lose sensitivity, but desiring to make it more specific. So we just remember that we have many vital signs that are predictors. And I would tell you the two strongest general predictors, of course, are the presence of tachycardia and the presence of tachypnea. That those two signs together alert us to deteriorating patients. And that as we aggregate more signs into this information, we can make it more specific. But we do want to remind ourselves that in the United States, so this is older data from 2012, that 500,000 so acute respiratory events occurred in US hospitals in 2012, and that 82.6 of those progressed to cardiac arrest, but prior to that time, they had prediction of respiratory depression. Respiratory depression. Okay, so, we say, oh, well then we just need to use the pulse ox, but any respiratory therapist in this audience, pulmonologists, and most nurses will tell you, pulse oximeter is not the best predictor. So now what can we do? So now we're going to step back and say, we're all going to work hard to develop modified early warning scores that are correct for our patients, to integrate that electronically, to have alerts that are sent and communicated to phones and iPads and pagers, whatever methodology you're using. But also to remember that based, and I love that this is all based on the opioid-induced respiratory depression, but I want to say respiratory depression overall, though we only have this profound evidence from opioid-induced respiratory depression. What we know is that we are not predicting it soon enough. They may have more abnormal vital signs as early as 4 to 6 hours before they have a respiratory or cardiac arrest, and that our spot checks are missing that because it's not frequent enough. So by the way, I'm not necessarily asking anyone to increase their absolute human interface and human evaluation. What I'm asking and what I would support is to have continuous monitoring remotely that aggregates our data and that brings that forward. Now, that's not a recommendation just from me. That's also a recommendation from pain management nursing, from the American Society for Pain Management Nursing, is to recognize earlier evaluation of patients who have respiratory depression, and in particular related to opioids. So now I just want to take a little bit of a segue and just remind us about the two processes that we look at, both at the cell and in the lungs. And those processes, those separate physiologic processes, are oxygenation and ventilation. And what we want to remember, what we want to remind ourselves about, is that we have these two separate processes. And ventilation and perfusion profoundly affect your end tidal CO2. So if we are able to look at end tidal CO2, which is measuring the amount of carbon dioxide in a volumetric method, the amount of carbon dioxide exhaled with each breath, that tells us not just one thing, it tells us two things. It tells us, do you have adequate lung function? And it tells us, do you have adequate pulmonary perfusion? Oxygenation is a much later predictor, and that's why end tidal CO2 in today's world could be very meaningful as a predictor and as a continuous monitoring capability to tell us about deteriorating patients. Remember, it's not just about moving gas out of your lung. It's also about moving blood flow through the pulmonary perfusion vault. And we all know that because part of your ACLS is when you're doing CPR, are you able to achieve an end tidal CO2 of at least 15? If you're not, then you're not doing adequate compression and you don't have adequate perfusion. So I like to remind you, this is my simple, very simple cartoon, is that CO2 lives in three spots. It's produced by the cell, it's regulated by the lung, and what's left over is what remains in the arterial bed. So produced by the cell is what we see in the venous blood, regulated by the lung is what we see as end tidal CO2, and what remains is what we see in the artery. I would tell you, number one, this is the most important, and I'm not going to monitor continuous PVCO2. But number two, this is the second most important. Actually, overall, I find this to be the least important in terms of evaluating patients. I want to know what's produced, and I want to know based on blood flow through the lung and ventilation of the lung, how do I best remove carbon dioxide? EtCO2, I would tell you, is probably the first predictor of respiratory depression. It is also a very stable and adequate predictor of poor pulmonary perfusion, and that would relate in particular, and especially during COVID-19, to blood flow through the pulmonary vault secondary to pulmonary emboli, microthrombi formation, or pulmonary vascular desiccation, which we know is a major influencer in the COVID-19 patient. So I never have enough time because I just talk too much. So I just want to use something really simple. Here's my basic information, that normal end tidal CO2 is 30 to 40. Above 45 means that I am not clearing effectively. It seems very strange to us. We just remember that normal end tidal CO2, 30 to 40, and above 45 indicates hypoventilation, and less than 35 means that your patient is either hyperventilating or they are not perfusing. Now, the only way I know is this a hyperventilation issue or a poor perfusion issue is I will need a blood gas. But I don't say you need an arterial blood gas. You can get a venous blood gas. And if you have a venous blood gas and your venous CO2 is 60 and your CO2 here is 35, then you look at your arterial CO2 to evaluate that as well. So I always like to say, all I have to really remember is what my PaCO2 is. My PaCO2 is 35 to 45, plus 5 on either side should be venous, less than 5 on either side should be end tidal. So all you need to memorize is PaCO2, 35 to 45. Add 5, that's normal venous, 40 to 50. Subtract 5, so that would be 30 to 40, correlates to end tidal. And so we can see in our situations that end tidal CO2 may be predicting very early on what's occurring for our patients. Now I'm going to move through this because I want to remind you that SpO2 and end tidal CO2 give us very different information. Saturation just measures the percent of sites on hemoglobin that are fully occupied by oxygen. And it's a beautiful measure, tells us how well we're oxygenating through the pulmonary alveolar capillary interface, the blood past the alveoli. That's a really important perspective, but it's a very slow changer. CO2 is an immediate predictor, and that tells us so much more about what's occurring. And there's so much for us to know about end tidal CO2 and CO2 as an indicator in general, beyond the state of this talk. So I just want to look at these two patients. These are both related to opioid-induced respiratory depression, and we can see how our patient is doing here with their dosing, their SpO2, and their pulse average. And here you are from 9 o'clock to 11:30. At 11:30, you get an ultimate alarm because you're dropping your pulse ox, but it's not outside of your alarm parameters until 11:30. But here, when you're looking at your end tidal CO2 average, you actually start to go up because your patient is hypoventilating and you have a much earlier prediction, fully 1 hour in advance. So end tidal CO2 can give us a very significant prediction. And again, if we look at our SpO2, you didn't get a prediction alarm until 11:30. Really, a full hour, maybe an hour and 15 minutes after the patient started to deteriorate. So by the time his respiratory rate has dropped to 7, you already have such a profound alteration in status. So end tidal CO2 can help us to have a high specificity and a very high indicator of patient status change. So really important for us to consider, can we add this into a methodology to allow us to evaluate our patients? Because we all know that right now, based on everything I've said, early warning systems suffer from high false alarm rates, false positives and false negatives, but clearly more false positives. And that the 3 most common reasons for deterioration, respiratory insufficiency, infection, and heart failure, respiratory insufficiency is the #1 cause of deterioration. We must do a better job to make this more specific with less false positives and less false negatives to bring us forward to understanding that the value of end tidal CO2 and SpO2 combined with respiratory rate will significantly and profoundly affect the value of alarms as we integrate this into our modified early warning systems tool and bring that forward to build a true safety net for our patients. So if we just look at basic patients with respiratory depression, length of stay, overall cost. And this is one methodology of monitoring end-tidal CO2 is called Prodigy in the Prodigy trial. You can see the very significant difference in patients who have greater than one communicator of respiratory depressed episodes. So they've had greater than one respiratory depressed episode, and then patients without that. You can see that if you had any episodes of respiratory depression, you increase your hospital cost and you increase your hospital stay. So really, really important. And then that data was actually titrated to exclude the outliers. And again, you can see a very significant difference between patients who have respiratory depression episodes and patients who do not. And so in that Prodigy trial, which evaluated this presence of respiratory depression and what respiratory depression does to length of stay, cost, and patient outcome, it becomes clear that we have to do a better job. So we think about all of our parameters gathered together to give us a modified early warning score: heart rate, blood pressure, EKG, respirations, SAT, Glasgow Coma Scale, urine output. But now we think also about the role of end-tidal CO2 as a primary predictor of respiratory depression, which we know is the #1 cause of out of ICU inpatient hospital arrest, and which we know significantly impacts outcome and length of stay. So to summarize, long day journey into life for our patients requires a vigilance in monitoring, requires continuous monitoring, that requires aggregated data. That may include labs as well as other meaningful data to make it more particular, more specific, and appropriately sensitive. Could the answer be end-tidal CO2? I would tell you yes. Could it also be other aggregated data like lab predictors? I would tell you yes. Could it be both? Would that make it even more particular? I would tell you yes. We are continuously searching for the Holy Grail. So this, just in case you don't know me, this is me. This is one of the MICU nurses, and this is one of our step-down nurses with our first patient who left the hospital after COVID-19. And we monitored him so vigilantly, and we included multiple methodologies. And of course, if you're a patient on a medical unit at Grady Hospital in Atlanta, Georgia, you will have constant surveillance and monitoring using modified early warning score. And then I would say we actually recently called it the M2 modified early warning score. M2 for Mady and McLean, M2 modified early warning score, integrating other variables to actually help us predict patients at risk. So I'm going to turn it back over to our moderator, Angela Craig. Thank you, Angela.
Well, thank you, Barbara. That was incredible. I love your passion, and it was so informative. And I want to, before we get to the questions, I quickly want to tell everyone how they're going to get their CE credit. There is continuing education for physicians, nurses, respiratory therapists, and EMS professionals, and it has been approved for 1 contact hour. To obtain your CE credits, you are going to go to saxtesting.com/INIT, and you will need to register, at that site, complete your evaluation, and upon successful completion, you will be able to print your certificate of completion. An archive on-demand version will be available on www.initiatives-patientsafety.org, and an email will be sent to all of the registrants when it is available. The on-demand version will be accredited for physician, nurses, EMS professionals, and respiratory therapists. So now, Barbara, I do have some questions that have come in through the chat, and I'm looking forward to your answers. There are a few questions I'm going to batch here that are about capnography. And Derek asked, was capnography evaluated in any of the studies for its effectiveness in early recognition of respiratory compromise?
Yes, so thank you so much, Eric. And at the end of my talk, I have quite an extensive reference list. It has been evaluated, in particular in the Prodigy trial, entitled CO2 as a predictor, as an earlier predictor and a methodology to evaluate respiratory depression. Now, again, reminding ourselves that it's easier to say, oh, this is an opioid-induced respiratory depression, and then we actually project that data to our bigger patient population. But as you may know, and as everyone else may know, that oftentimes we've had difficulty with calibration. We always have a question about the signal. So again, reminding ourselves that we want to assure signal veracity in the best way that we can, and to utilize that information as part and parcel of our framework in evaluating patients. So end-tidal CO2 plus SpO2 plus respiratory rate will give us a much higher level of prediction, and that has been evaluated in multiple studies.
Awesome. And Robert also, just to tie into that, Robert asks, how do you adapt the end-tidal CO2 to the chronic hypercapnic patient?
So thank you so much. What a great question. So the beauty of evolution in technology is that it still requires the intellect of a provider. And that means that we're still important at the bedside. So if I have a patient who is traditionally hypercapnic, all I'm going to do is adjust that information. And that's why when you look at any kind of a relay data, like for us with a modified early warning score, I can look back from my phone, I can look back to see how much change has occurred. So if you are a traditional hypercapnic patient, you're traditionally a patient who has a high level of CO2 in your exhale tidal, volumetric tidal CO2, and a high level in your arterial CO2, then I'm going to set my indicators to be much higher on that patient population, on that individual, knowing that he normally has a PaCO2 of 58 and a normal end tidal of 53. I'm going to use that to build the parameters to fit that individual patient.
Awesome. Awesome. Thanks. Alicia asked if you have any thoughts on comparisons between MEWS slash Rothman slash Epic DI.
So my only view is I think that you in your own institution need to use what works best and what's easiest for you to actually implement, and then you must massage it. So of course, Rothman is the Rothman index for anyone who's interested, and you can Google it. You can look at all of the publications that utilize the Rothman tool. I think that the Rothman tool and the Rothman indicator is an excellent indicator. It claims to have a much higher specificity and less sensitivity than MEWS. And I think that everyone together is trying to operationalize a best methodology. And at this moment in time, I would tell you there is no best methodology. So I think the first step is for us at the bedside to make a commitment to a methodology that we can implement relatively easily, go back, pull our data, look at false positives, look at false negatives, look at code blues, look at ICU admission, and then look at the aggregate of your data and build a program that fits what you're seeing in your population. And that will take parts from Epic, News, MEWS, WOVS, Rothman, all of them together. And we're all actually trying to find that best methodology. And when somebody finds the absolute best methodology, I'm quite certain we're all going to integrate that.
Absolutely. Well, I want to close this question section by stating what Brenda said in her chat box. This webinar should be mandatory for all clinical healthcare providers in the USA. So thank
Oh,
you,
thank
Brenda, and
you.
lots of accolades on the chat box, and I agree with every one of them. Thank you so much, Barbara. And I'm going to hand this over to Tracy at this time.
Thank you, Angela.
You're welcome, sister.
And we'd like to thank everyone for attending this session. This concludes our webinar for today. I wish everyone a pleasant rest of their day.